This is Dr. Abdul Abdellatif, Assistant Professor of Medicine at Baylor College of Medicine in Houston, Texas. I practice both academic as well as private practice. I'm the founder of Kidney Hypertension Transplant Clinic at Clear Lake Specialties in Houston as well. The medication we will be discussing today is Pegloticase, which is Krystexxa, a medication approved by the FDA, already in use for treatment of refractory gout in patients who has been treated with other commonly used medications called urate-lowering agents, including allopurinol and urate. Now, the medication has already been in the market and in use. We actually use it as rheumatology and other practitioners use it to treat patients with uncontrolled gout. Now, the unique thing about the new studies we're doing with this medication, when we did the pivotal clinical trials, actually, the drug showed 42% what we call durable response rate, means everyone who got it responded, had an excellent response of dropping their uric acid from 10 to basically less than 1. And some of the patients had incomplete response. Now, when we treat patients with gout, gout is basically precipitated by high uric acid in the bloodstream. The uric acid gets precipitated in the joints and sticks there and stays there. Now, if it does not get regulated or controlled in the bloodstream, it continues to accumulate, leading to what we call also tophaceous gout, means the patients will have tophi buildup as well as destructive process in their joint called destructive arthropathy from the active inflammatory changes and change in the architecture of the bone itself. Now, this medication comes into play as approved by the FDA to treat patients who has been refractory to urate-lowering agents, which includes allopurinol and urate. And in that definition includes a patient who's basically has been on either one of those medications and not meeting the recommended guidelines of keeping the uric acid less than 6. The other recommendation is if a patient is, let's say, allergic to either one of those medications, cannot be on it, this medication becomes an option for them. If the patients still have tophi and they're being treated and it's not getting better, this medication becomes an option for them. If the patient continue to have gout flares and they're not responding to the other agents, this medication also becomes an option for them. So it's a wide spectrum of patients can be benefiting from this medication if it's used in appropriate setting. Now, what we did for when we actually presented at ASN is a way of looking at optimizing the response and effectiveness of this drug. So what happened is this drug is pegylated. So it has a peg that surrounds the medication to protect it while it's in the body to give it longer half-life so it works better, okay? So the immune system is tricky. It can find the peg on the medication itself and try to neutralize the medication or get rid of it faster and decrease its effectiveness. So what we noted in the transplant population that was included in a former trial looking at 30 patients, 7 of them were transplant patients, that these patients had more durable response than the patients in the pivotal trial, which were not on immunosuppressive medication. So from that stems the idea of if the patient is taking a concomitant immunosuppressive medication with the medication, means we calm the immune system down, we make the medication work a little bit better and the patients have better response and less immune reaction to the medication itself. So that's what brought on the PROTECT trial, which is using Pegloticase in kidney transplant patient to treat uncontrolled gout. And what we had presented at ASN is actually the trial includes 20 patients, five of them had completed the trial, which is 6 months. And the patients who had completed the trial, we did a data cut at that point and showed that our response rate was 80% or more in these patients without having infusion reaction or a significant side effect from the medication that made them withdraw. Actually, none of the patients had anaphylactic reaction and none of the patients withdrew from the trial because of side effect profile. So we basically emphasize the fact that in this vulnerable patient population, which at higher risk for gout, approximately 13 times, 10 to 13 times higher risk than the general population for gout for many reasons, which I'll explain in a minute, that this medication actually showed significantly better response. Now, the drug is indicated to be used in patients across the board. So this is, we're not looking for an indication. We're just doing a phase 4 clinical trial to look at the safety and effectiveness of the drug in this transplant population.
Mhm. Currently, how is this transplant population treated? What options do you have? Mhm.
Sure. Currently, the patient is basically treated as any other patient with gout. We treat the patient with allopurinol or urate unless if there's a contraindication to those drugs in this patient population. For example, if you cannot use allopurinol with medication called Imuran that we use in transplant because there's a drug-drug interaction that may lead to bone marrow suppression and precipitating anemia or leukopenia in these patients. So it becomes contraindicated in that setting to use allopurinol in these patients. So that's one scenario. The other scenario is because we have to control the immune system to prevent transplant rejection, we put these patients on medications such as tacrolimus or cyclosporin, which are the family of calcineurin inhibitors, and there's other medications in the market. These medications themselves actually decrease the kidney's ability to get rid of the uric acid, which causes worsening hyperuricemia, exacerbation of gout, or a new onset de novo gout in these patients. And therefore, Krystexxa comes as an option for these patients who unfortunately may not be able to be treated with the other medications or have been treated, but because of their increased risk that they're not responding to the other therapeutic agents available.
Mm-hmm. So this treatment in this patient population didn't show any of those adverse events that you described with other treatments.
Yes, I mean, basically, when we treated those patients, we did not have any patient in the clinical trial that stopped the trial because of any adverse events. One patient basically had incomplete response, meaning their uric acid did not go down. Most likely, they broke through and developed some antibodies to neutralize the drug. And another patient was just worried about the COVID pandemic and did not want to be in the trial during that period.
Mm-hmm. Mm-hmm. So what's next in terms of this treatment for this condition?
Actually, what's next is actually very exciting. So, multiple investigator-initiated publications has been already in the literature about using immunomodulating therapy such as Cellcept, Imuran, leflunomide, methotrexate to basically minimize this immune reaction that we see that for the immune system to develop antibodies to minimize the effect of the drug. Therefore, if you take all those studies and you look at a summary of the results that we're seeing approximately 80 to 90% response rate instead of the 42% response rate that we saw in the pivotal trial when the patients were just given the medication without concomitant immunosuppressive medication or immunomodulating medication. So basically the goal for the treating physician or clinician is to give the patient the best chance to respond to the drug because it may be the last option for them to control their uncontrolled disease.
Mm-hmm. Yeah, and it looks like a promising option as well.
Very, very promising from clinical experience,
Mm-hmm.
seeing significant improvement. And not only that, actually, we showed there was improvement in pain score as well disability score in these patients when they were treated with this medication.
Okay. Is there anything else you'd like to leave us with today?
I like to really comment on the fact that gout is a very prevalent condition that is undertreated and underdiagnosed because most of the patients either they don't inform their clinicians of the disease itself or they may blame themselves for having the disease, although 90% of the time is actually hyperuricemia is precipitated by renal insufficiency. And most of these patients may not get the appropriate therapeutic options available for them to control their disease. So I encourage our community to go back and start to check uric acid as routine when they see their patients, to make sure either the patient is predisposed to a new onset gout, or if the patient is at risk for gout exacerbation if they already had the disease itself.
Mhm. Okay. Well, thank you.